Ben, Anita, and I are going to let you be an honorary member of a Stanford trainee. I'm Frank Arko. I'm going to talk to you about my use of the device on the thoracic side. I've sort of gone over it, or switched to it maybe about 18 months or so ago for a variety of reasons. One, I just think the key for me is low profile. You give me something that's 19 French for the majority of the cases. I've got a very complex patient population, a lot of whom are women, and women with thoracic aneurysms, and you're doing a endovascular, have two things. One, up top, very big vessels. Down below, the vessels have a tendency to be very small and heavily calcified. So that's probably one of the main reasons I've used this low profile. I wasn't quite sure what to think of the dual sheath technology. I do like it, though. I will tell you that if you're going to do stuff off-label with this device, i.e. make fenestrations with it, I'm not encouraging that, but the dual sheath technology makes the reloading of this device actually relatively easy. I think it is actually a true dissection device. You've got a device that has absolutely no metal up at the top. And I think that makes it nice, at least for our practice. This is this dual sheath technology. It's an integrated dual sheath designed to minimize access vessel manipulation and also provides an atraumatic thoracic aorta navigation. The outer sheath is designed to provide you pushability through the access vessels. And then once you're up through that, you can really then just use this inner sheath to provide navigability all the way up to the top. If you don't want to use the dual sheath, you don't have to. You can put the whole device all the way up there and do sort of a reverse deployment. And occasionally I'll do that. I'll show you a couple cases a little bit later. You can see here with the small technology and the dual sheath technology, access-related complications are very low. And the risk of stroke when you're up in the arch was also very low in the clinical trial at 1.8%. They've got a lot of stuff within a device itself that I think is helpful when you're looking to garner seal up at the top and a variety of different pathologies that you might be treating. You've got the alignment zone, which has got very low radial force. So if you're putting it up in the arch, you need to cover up one of the branch vessels. I think the risk of having a retrograde type A dissection is low, but having that sort of gives you a little bit more seal. You then have the next zone, which is this proximal seal zone with this very high radial force, and you've got a flex zone with really no radial force, and then you've got variations of the radial force through the rest of the graft, and then distally, very high radial force with very good seal zone. And with this device, what I've been most impressed about, and I really think it's that inner sheath, is when you pull this down and you're really trying to get that distal seal zone, a lot of the other stent grafts on the thoracic side will have a tendency to pop up, and you can't quite get them aligned along this curve that you're coming down. This device, you can really sort of keep pretty good distal tension on the device and really deploy it very orthogonal to the vessel. Very similar, they have the other device that doesn't have any of the free flow up at the top. Again, I like this device mainly for dissections or anything that I may have to do in the future with regards to fixing the AFib and with regards to my cardiac surgeons. It has this S-bar technology that does not go along the entire graft. You want to get that to the outer curve. I think the benefit of this, and it's just in the top part, is in some of the other endografts, as you sort of put them up there along that greater curve, sometimes you can have a little bit too much conformability. So the conformability over a period of time, the stents will start to stack on itself, and you'll get a little bit of distal migration. This sort of gives this added columnar strength and helps to maybe prevent some of that stuff. Gives you a bunch of different sizes, as you can see here, 22 all the way up to 46. They've got tapered grafts in all their devices. The other nice thing about the company, they actually make you a custom-made tapered grafts. It takes a little bit longer to get those, but if you need what I need, you can just say, can you make me 10 of these? They'll keep them stacked, and then when I need them, they give them to me. The long lengths reduce the number of devices that you have to implant, so I think it's better. When you get in the proximal landing zone, I think it's key. I think there are branch devices. I use TBE. I actually use it a fair amount, but it doesn't meet everyone's suitability to put that device in. So I think this is always going to be important. I mean, in my last case I just did was a carotid subclavian bypass with placing this device up. When you do these bypasses in the arch, everyone sort of gets concerned about having a single vessel off the arch to supply everything. If you actually take a look at the data, that data for these bypass grafts through the neck is actually very, very good with very high patency rates. These vessels are typically non-diseased, they're high flow, and done technically well, really not much in the way of issues. So here's a case, 67-year-old male, prior type A dissection by a CT surgeon. Had a zone 2 TEVAR with left subclavian transposition and coiling, had a Medtronic Valiant 36-200 already placed, now presents with this false lumen filling distally. So actually went about 6 years without having to do anything further down. It was then referred to me. I'll sort of show you this case here. This is sort of where I inherit my stuff. So this is a non-contrast. I'm not sure why, but this is the, you can see the 3D reconstruction over there playing actually quite nicely. And this is where it's getting up to 6.5. I like to stage these. He's probably going to need some stuff done distally later on, but this is what we did. In this case, I just stented, I think, one of the renals to shut off the re-entry, then extended down to the celiac. You can see we've got very nice thrombosis of that distal thoracic aorta. He just had some large fenestrations. He's not that big here. I'm going to wait until this gets to an appropriate size, but this could be managed in a couple different ways, in my opinion. This is another one, 46-year-old male referred to me, had a prior coarctation open repair with actually a graft. He's become with pseudoaneurysms at the proximal and distal anastomosis. Looks like they tried to sort of reimplant the left subclavian on that. Important when you're doing coarctations to really understand the prior operations that they have done in them. Otherwise, if you don't, you can really get into some bad problems. This is the 3D reconstruction. I actually watched him for about 12 months. He started complaining of increasing pain. Frankly, I think he was just nervous. These aren't the biggest pseudoaneurysms I ever did, but they did grow over the years, so we went ahead and treated him. I did a carotid subclavian bypass. I don't like to do branch cases in young people with this sort of an anatomy that's got a lot of angles. I just think long-term they'll do better with the bypass, and he actually did quite well and sort of back to doing his normal stuff. We do have stuff, right now in our institution for treating patients, just some zone 0 stuff that we've done. We were also part of the Nexus trial. I like this graft. I think it does well. I think the inclusion-exclusion criteria for it is hard. I was very excited early on, so I think these are things to remember. I think my first 4 were all approved. My next 10 were all declined. So my hit rate for this is about 10 or 15%. But once you get them approved, I really think you can sort of do some things off-label with them. And this actually had a nice result here with it long-term. I'll just sort of show you the 3D reconstruction. We coil that. And this is 1-year follow-up. He's actually about 2.5 years, and his aneurysm completely disappeared. He actually presented with a vocal cord paralysis and has slowly gained that back up, even without the decompression. Here's another case, basically decline for everything in any clinical trial, mainly because there's already a stent graft there. Can't even get anything with compassionate use. I can guarantee you this would be declined if it was in the zone 0 TBE original trial. But you take them off trial, you do the procedures. I basically staple off the left carotid now and just do an end-to-end with the graft and bring the graft all the way over to the left subclavian. But you can see relatively large aneurysm through there. Again, a prior type A with a distal descending thoracic that I actually put in, but he presented about 2 years later. Again, I think it's this conformability that occurs, and that stent graft actually migrated back a fair amount. So nice result with this. This is really what's nice about Terumos. They really give you sort of stuff that you can do on the open as well as the endovascular case. So here's a 34-year-old male with Marfan's, prior mechanical aortic root, ascending aortic replacement. This was then treated with the Thoraflex, and then we extended that with a reduced sternotomy, total arch replacement with the frozen elephant truck, and then extended that down with the Thoraflex. His distal, you could say, well, he's got Marfan's, but his distal aorta is totally normal. He may degenerate over time, but that we can then sew to in the future and do open standard repair. This is a case as we're doing it, and actually worked pretty well. This is his 12-month follow-up. You can see very, very nice aortic remodeling through that distal aneurysm. You'll see a very nice seal and not much radial force through the majority of that graft, which I think is going to be beneficial, and the rest of his aorta looks pretty good. Just sort of advancing through some, I like to show these because these are these women that I think are incredibly difficult to treat, in my opinion. This is a bunch of penetrating aortic ulcers. You can see it right there at the left subclavian. She's got a lot of calcium. She's old. I could maybe make the argument to go further in on this case, but I wanted to sort of see what I could get and try to avoid anything and avoid any metal up at the top. So the PAU looks a lot bigger on the 3D reconstructions, and we'll just let each one of these play. But you can actually see here, I can do this case, get a nice result, not have to put any metal going across that left carotid or the innominate artery, and I don't have to worry about those, free flows going into either one of those vessels. And I think if she gets into a problem, this becomes a very easy repair for the cardiac surgeon. One last patient. This is a patient with a Marfan's. Again, the ascending completely replaced. Already had a carotid subclavian bypass, so we'll do that, so it makes our life a little bit easier. These are the axial images. Should play. You'll actually see how big this is. Interestingly, we'll see how this lady does. I had her set up for me to fix her from her graft. She's got Marfan's, and bring a tapered graft all the way down her celiac, and I was going to basically do her open repair about 2 or 3 days later because she's pretty young. However, she developed an abscess around the root, and we had to treat her with IV antibiotics. She was not a very good candidate for a redo operation for that. She actually did pretty well, but we'll show you this case. We'll show you how this device tracks with the 2 sheaths that you have. I think you look at this and say, it's like pretty complex anatomy. But this is the device. It'll track up very nice up through there. You get very nice alignment of the stent graft within the previous surgical graft. Again, she has Marfan's, and you'll sort of see this final repair. And I extended her down to about 3 centimeters above the celiac. I let her go. She's in the hospital for about 2 days. I discharged her. I don't have her follow-up because it's a pretty recent case. Here's another one, prior type A repair. I mean, I show you just so you can see how it tracks through the challenging anatomy. Prior ascending repair, I'm not sure what they did in the descending. This was actually referred to me from Raleigh, which makes me curious because there's some good places there. These are the axial images. You'll see this. This is an 82-year-old woman who basically said, I want this fixed because I don't want to die of a ruptured aneurysm. So I said, okay. She's about 4'11", but I think her aorta could fit into Shaquille O'Neal because that's how much tortuosity that she had. And you'll sort of see this sort of tracking over. You see this large aneurysm. I didn't even put those coils in. She came to me with the coils. I think her stent graft had just basically migrated all the way back. That's a 37 graft that migrated back. I put a 46 in there, and you'll sort of see it track up to the prior stent graft. You got to give it a little bit of nudge through the tortuosity, but it's going to go up through there pretty well. We'll get the last one to play, which is the final image, but actually worked out pretty well. I have to do some stuff distally for her as well. But anyway, those are the cases, and thank you very much.
Awesome. Thank you to Terumo for lunch, and I know we're a little bit over time, so thanks to the speakers, and enjoy the rest of the day.